Okay, I think we are good to get started. Good morning, everyone, and welcome. Thank you so much for being here today. Kauvery Hospitals, in association with the Hindu Wellness Series, is proud to present today's conversation on liver health and transplants. My name is Yashaswini, and I will be your moderator for today. We are particularly pleased to host this conversation ahead of World Liver Day, celebrated tomorrow on April 19th around the world, to raise awareness about liver health and disease. This year's theme for World Liver Day is on being vigilant and regularly seeking healthcare, and we have with us today two doctors to help us take that first step. Over the course of the next hour, we will hear from Dr. S. Velmurugan and Dr. Swaminathan Sambandam from Kauvery Hospital. Dr. S. Velmurugan is a gastroenterologist with over 26 years of experience in the field. He completed his MBBS from Stanley Medical College and MS from Madras Medical College before doing his FRCS from the Royal College of Surgeons in Glasgow, as well as the Intercollegiate Board in the UK. He has been with Kauvery Hospital for over 10 years now and is the HOD of Surgical Gastroenterology and Senior Consultant at Kauvery in Chennai. Today, he will be speaking to us about liver tumors, preventive measures, symptoms, and treatment options. Also joining us today is Dr. Swaminathan Sambandam, a senior consultant and lead of multi-organ transplant of liver, kidneys, pancreas, and the small intestine at Kauvery Hospital. He completed his MBBS from Chengalpet Medical College, his MS from Madras Medical College, and then went on to finish his MRCS from the Royal College of Surgeons in Edinburgh. He also completed the ASTS Transplant Fellowship at the University of Iowa Hospital in the US. Today, Dr. Swaminathan will be speaking to us about the causes of liver failure and transplantation. Before we move on to our conversation for today, a few quick announcements from me. Please keep your questions coming in the Q&A box at the bottom of your screen. We will be looking to address as many of them as possible in the second half of our session. We are also all doing our very best to ensure that the next hour is a time of learning and sharing. But in case of any technical glitches whatsoever, please bear with us and we will be back to normal programming as soon as possible. And now, with no further delay, I will hand over the spotlight to Dr. Velmurugan. Doctor, the stage is all yours.
Thank you. Screen share. Good morning, everyone. First of all, I would like to extend my gratitude and thanks to the Hindu group and also the Kauvery Hospital for arranging this awareness on liver diseases. And a special thanks to our Kauvery management. So two of us from the Kauvery Hospital are going to give a talk and we will be answering your questions. I'll be talking about the liver tumors. Dr. Swaminathan will be talking about the role of a liver transplantation and all. This is a very short talk about awareness about the clinical symptoms and management of liver tumors. First of all, a little bit of basics for the public people. The liver is situated in the right upper part of the belly. So the liver is situated in the right upper abdomen. And the anatomy, it looks like this. You have the liver produces bile, it comes from the liver, the bile comes from the liver, goes through the bile duct, and sometimes it is stored in the gallbladder. It does not produce, the bile is not produced in the gallbladder, the bile is produced by the liver, but the storage happens in the gallbladder. And then it comes down into the intestine, and the bile mixes with the food and helps in digestion, especially digestion of the fat in our food. This is a very important slide. The public should be aware of. The whole concept of liver management, surgical management, including liver transplant, is based on this anatomy. Liver has got 8 parts. We call it as segments in medical terminology. So there are 4 on the left side and 4 on the right side. Every segment, every part has got its own blood supply own blood drainage, and also it has got its own bile pipe, which all joins together and form a single bile pipe. So every individual part has got its own anatomy and they are separate to each other. Even though it is molded as a single liver, but it has actually got 8 segments, 8 parts. This is a God's given gift. This helps us to remove part of the liver without causing major problems. And also it helps us to get a donor, living donor from a related donor so that we can use half of the liver or even 3/4 of the liver to a diseased patient. Now, so we can remove up to 3/4 of the liver. Sometimes we do call extended hepatectomies. If it is extended right hepatectomies, which means removing up to here, leaving only segment 2 and 3. But this segment 2 and 3 should be a healthy liver. So we can remove up to 3/4 of the liver as long as the remaining 1/4 of the liver is healthy. But if the remaining 1/4 of the liver is not healthy, then it may not be enough to do the necessary function. So it's very, very important to understand the anatomy. That's why I put that slide on. The liver functions, as I told you earlier, it produces bile, and bile is important for digestion of fat in our food, and it clears the bilirubin in our blood. When the red cells, when the red blood corpuscles, after 100 days, it gets destroyed, and the bilirubin is one of the products, and it clears the bilirubin. If this accumulates, we get jaundice. Jaundice is basically an accumulation of excess bilirubin in the blood. It clears toxic products which is absorbed in the intestine. One of the common things, ammonia. Ammonia is produced in the intestine by the bacteria in the intestine acting on the food products. This ammonia goes into the liver. Liver detoxifies a lot of things what we eat. It is a filter in our abdomen. All the toxic products we ingest, it acts as a filter, cleans the blood and sends it to the heart. And it is an important factory where it synthesizes the blood proteins like albumin and the blood clotting proteins, fibrinogen, and also it's a very important producer, and also it stores iron and glucose. Initially, if you are fasting for 24 hours, your glucose level are maintained in the initial 24 hours by the stored glucose in the liver. The liver releases the stored glucose in the liver to the blood and maintains your blood sugar level. So if you're starving, the liver is working for you to supply the glucose into your bloodstream to maintain your brain function and other cell function. And because of the protein synthesis, regulates blood clotting. So if you get a liver disease, your blood may not clot, and there is a more chance of bleeding tendency. Dr. Swaminathan will talk about it later. And it is a very immunoprotective organ. It is an immunoprotective solid organ. It provides a lot of immunity against infection. So when you get a liver disease, when the liver is damaged, you are immunocompromised, your immunity goes down, they are prone for all infective complications. So what are the causes for liver damage? There are 3 things which damages the liver. Remember that there are 3 things. The most common thing, especially in our part of the world, is increasing alcohol consumption. It's very, very sad that we are seeing even young people getting addicted to alcohol and losing their quality and quantity of life and causing problems to the family and their income and everything, financial problems and health problems. The second thing is the fat, increased amount of fat in the liver. If we eat too much carbohydrate, the carbohydrate will get converted to fat and it will get deposited in the liver and it will replace the liver tissue. The fat will replace the liver tissue, and this fat deposition in the liver will create inflammation in the liver, which will lead to fibrosis, which means scarring of the liver, which can over a period of time, it will become what's called a cirrhosis liver, which is basically an end-stage liver disease, for which the only treatment will be transplant at the later years. So these are the 2 important things we need to avoid to protect our liver. And viruses. Hepatitis A is usually due to unhygienic food and water. Usually goes away without causing much problems. Whereas hepatitis B and C, usually blood-borne viruses, these viruses can lodge in the liver and cause problems and damage the liver and cause the scarring of the liver over a bit of time. And the other important thing I want to highlight is the drugs and toxins. A lot of people take medicines without doctor's advice over the counter and they take it long term. All these drugs are metabolized by the liver and it can cause liver damage in the long run. Unfortunately, in our part of the world, we are seeing this rat killer poison being taken with a suicidal intent. These rat killer paste and all, they are very lethal actually. Now our government has taken some good initiatives to stop that being sold in the market, but still we do see those happening in our part of the world. A little bit 2 or 3 slides about the liver tumors. I'm not going to go into the complexity of the liver tumors. I'm going to tell you about the basic things. The liver tumors can be benign. Benign means they don't cause any, they will not spread into anywhere. They just grow locally. They usually do not cause any problem to your life. Majority of them can be safely observed. That's called benign. Malignant means they can spread to any part of the body, which basically is cancer, and can cause problem and can cause risk to your life. These cancers can grow within the liver itself. It's called from the liver itself. It's called the primary cancers. The second one is a secondary cancer, which means the cancer from the intestine or somewhere else in the body can spread to the liver. So the liver being filter of the blood, all the cancer cells can lodge in the liver and can get secondaries in the liver. That's how we classify liver tumors. Majority of the time, I see patients getting very anxious and coming into my OPD with a report saying that, sir, we did a master health checkup. The ultrasound scan shows some cyst in the liver, some blood containing cyst in the liver. They get really panic about it. They think that they got cancer in the liver and they are really sleepless, very anxious. Usually, majority of them are benign. Majority of the liver cystic lesions are benign, simple cysts. They are just simple fluid containing cysts in the liver. We don't need to do anything, just a reassurance. It will not affect your life. Similarly, the blood containing tumors, the hemangiomas, the blood vessel tumors, they do not need intervention. They might grow over a period of time, but usually they don't cause problems. They can be safely observed unless they are very huge, causing pressure symptoms like discomfort or jaundice or anything like that. So majority of the tumors in the liver are benign. So don't worry if you see something in the routine scans. So just to get your doctor to have a look at it, and then he or she will do whatever is necessary. Then people can get abscesses. You can get fever and right-sided upper abdominal pain. Usually they settle very well. We give antibiotics and we suck the pus out of the liver. We don't need surgical procedure for these abscesses. Majority of them are dealt conservatively, either by just antibiotics or by ultrasound scan guided aspiration or drainage. Surgical drainage and all, it's all old fashioned now. We don't do that. We do a non-surgical drainage procedure for these abscesses. So we don't need to worry about it. This is quite common in alcoholics where they take unhygienic food. They don't take care of the hygiene when they eat. Hydatid cyst is a very special cystic infected cyst in the liver. It's usually due to a parasite called the echinococcus. It is common in people who have dog as a pet in the house. This parasite lodges in the liver and can grow, but that has to be removed. Sometimes you might get a report saying that there is very large cyst in the liver, 15 centimeter, 20 centimeter cyst in the liver. That needs to be evaluated by a CT scan. It's called a cystadenoma. If they diagnose as a cystadenoma, definitely it has to be removed, safely can be removed, because it has got a tendency to become malignant over a period of years. Similarly, adenomas, this is common in young females who take contraceptive pills for a longer term. Okay, contraceptive pills are one of the known etiological factors for developing adenomas in the liver. It has to be removed because they can become cancerous later on, but common in young females who are taking contraceptive pills for a longer period of time. So malignant, I'm going into the malignant, the cancer, liver cancers. The primary liver cancers are called, majority of them called hepatocellular carcinomas, called HCC. Usually, primary liver cancers do not grow in a healthy liver. Usually, more than 95% of the time, they develop in a scarred liver or a diseased liver called a cirrhotic liver, or in people who have hepatitis B or C in the liver. Very, very rare to get a tumor in a healthy liver. So, but rarely you can get special tumors like this cholangiocarcinomas and fibrolamellar carcinomas, which can happen in a healthy liver, where they constitute only less than 5% of the liver tumors. So, if you keep your liver healthy, then you will avoid developing all these sort of problems, life-threatening problems later on. Secondaries, just a word about secondaries. People all think that if somebody's got a colon cancer, which has spread to the liver, it is stage 4, and that's it, it's gone. You know, they go for yatra and they decided that I'm going to go out of this world. Nothing like that. Even if you have colon cancer metastasis in the liver, if there is no other metastasis anywhere else, if you have a colon cancer with the liver metastasis, if you remove this metastasis from the liver, there is a 25% chance that you will live for at least minimum 10 years. And there is almost 25% chance that it will be cured. So all secondaries in the liver doesn't mean that it's all only palliation. There is a curative option if you have cancer metastasis in the liver, especially if the colon cancer metastasis and something called neuroendocrine metastasis and renal metastasis. In these 3 cancers, if you remove the metastasis in the liver, you will lead a normal, longer life in the long run as any other people. So, what are the symptoms of liver cancer? Usually, it's very vague symptoms. Majority of the time, it is found out by investigations. You generally feel tired, you lose your appetite, you start losing weight, and there may be a low-grade fever in certain, a low-grade fever, not a high-grade fever, low-grade fever in certain group of patients. Majority of the time, it's detected incidentally or during a routine follow-up of a patient who has got cirrhotic disease or a diseased liver. Anybody who's got a cirrhosis of the liver, they need every 6 monthly ultrasound scan and a tumor marker called AFP blood test to make sure that they don't develop tumors in the liver so that they can be detected early and addressed. So if you have a diseased liver, you need every 6 monthly ultrasound scan and the blood test. The blood test, what we do normally is the liver function test to look at the function, how good your liver is working, and the tumor markers, usually the alpha beta proteins called AFP. Ultrasound scan is a screening modality, simple scan, which can screen majority of the liver problems. But once you find a liver lesion, the ideal test, the gold standard test to find out what tumor it is the CT scan. The liver protocol CT scan will tell us all the information what we need. Rarely, doctors might suggest MRI scan, but usually it's not needed. The PET scan may be needed in certain cases where the doctor wants to know whether it has spread anywhere else in the body, because PET scan is quite specific in picking up lesions outside the liver. So PET scan is one of the newer modalities we are using for looking for distant metastasis before planning our treatment. Generally, any cancers, every patient will ask, have we got a biopsy confirmation? But in liver cancers, there is no need for biopsy confirmation. We do not biopsy the lesion unless there is uncertainty in the diagnosis. Because if you biopsy, if the imaging and clinical picture shows that it's most likely a tumor which needs to be removed, it has to be removed. The reason is, if you go and biopsy it, if it is a cancer, there is a chance that the cells will spill and you may lose a chance of curing the disease. You might get spillage of the cancer cells and then you can get recurrent. So in liver tumors, routinely we don't biopsy it unless there is any uncertainty in the liver. Effective treatments are available for liver tumors. As I told you earlier, if it is a healthy liver, the primary modality for liver tumor is removal of the tumor. 2/3 of the healthy liver, even 3/4, we can go up to 3/4 in a very good liver. And the remaining liver will regenerate, and within 6 weeks, it will regenerate to almost 70 to 80% of its original size. So liver is an amazing organ which will regenerate. I always tell my patients only 3 things will grow in our human body. One is the liver, the second one is the hair and skin and nail. Even if you cut it, they keep on growing as long as you're alive. And the third thing is your knowledge. Only 3 things will keep on growing, even if you cut it. So if a tumor occurs in a diseased liver, in a cirrhotic liver, then if it is a mildly diseased liver, mildly cirrhotic, then we remove it because the rest of the liver may be enough to regenerate. But if it is already a cirrhotic liver or diseased liver, then we will not be able to remove it because the remaining liver, what we leave, will not be enough to regenerate to maintain all the liver function what is needed for survival. So usually they need a liver transplant. But even for a transplant, there are certain criteria which Swaminathan will tell. And if it satisfies the criteria, they need a transplant. If removal is not possible or transplant not possible, then there are other options like chemotherapy, radiotherapy, which is called a TACE and a TAR, and we can inject alcohol into that lesion or radiofrequency ablation. There are other treatment modalities which will prolong the life comfortably. And liver metastasis from colon cancer, you remove them, the survival is prolonged. As I told you, almost 25% of the people will be able to give 10-year survival rate, even if they have metastasis in the liver, as long as there is no other metastasis anywhere else. So this is my final slide. So to avoid all these problems, what I mentioned earlier, you follow this. That's all. If you follow this, then you don't need to come to us. You don't need to listen to all my previous slides and worry about it. So first thing is the diet, healthy diet. So low calorie, high fiber diet, less carbohydrate and low fat diet. Very important. Soru is important. Rice is important. Yes, we do need carbohydrates, but we do eat a lot of carbohydrate, which has to be avoided. So many millets and the mari, you have to take a lot of millets and other things, a lot of vegetables. Vegetables are very, very good. So take a lot of vegetables and fruits, and high fiber diet is very, very important. And the second thing is exercise, at least half an hour a day. Any mode of exercise, half an hour, 30 minutes, at least 30 minutes. These are the 2 things which will protect your liver. And certainly you have to stop alcohol and stop drugs, especially IV drug abusers. They have to stop using it and get vaccinated against hepatitis. Even nowadays, the hepatitis vaccine is in the vaccination program even for children. So you vaccinate your children even at an earlier age when they are a child, so that you can protect them from getting hepatitis B later on. To prevent hepatitis A, which is common in our part of the country, you need to wash hands and have hygienic food and water to prevent hepatitis B, because it is spread by contamination, water and food contamination. Also, you should practice safe sex because it is a blood-borne organism. So you have to prevent hepatitis B and C. And please do not take unnecessary medications over the counter, and do not believe in unscientific medications which is sold outside. And I thank you very much, everyone, for listening. Thank you.
Thank you so much, Doctor, for walking us through the anatomy, the functions, the possible diseases. Understanding the organ is such an important first step to ensuring its health. But to continue the conversation today, I invite Dr. Swaminathan to speak to us particularly about transplants and their, as a continuation of what Dr. Velmurugan just shared with us.
Good morning, everyone. Thank you for having me and organizing a wonderful meeting. Thanks to Hindu and Kauvery management. Dr. Velmurugan has given a fantastic overview of liver functions, the basic liver diseases and the liver cancers in particular, and lots of the fear that's revolves around the patient. He's cleared all the doubts that liver surgery is safe, it can be done for liver cancers, and the cure can be achieved for liver cancer, which is a very a key point to take home, that liver cancer is not a death sentence. It can be cured, is what Dr. Velmurugan has clearly emphasized, and that's a wonderful take-home point here. And I'm going to be talking about liver transplantation in particular. Liver transplantation is not a new procedure. It started way back in 1963. We are looking at almost half a century of evolution in liver transplant technique. 1967 is when first successful liver transplant was done in the US. Subsequently, all the countries took up liver transplant, and liver transplant has become an extremely successful procedure in India. And in fact, in the last decade, India has been telling the world how to do liver transplant. In fact, we pioneered the technique of living donor liver transplantation purely because of the population, volume, and the quality of work we do in India. So liver transplantation, Dr. Velmurugan has mentioned about cirrhosis, which is basically the end stage liver disease. Basically, after we exhaust all the medical management, then the liver goes in for the initial stages is what is called as inflammation of the liver due to various causes, which was previously mentioned, like alcohol, fatty liver disease, hepatitis C, hepatitis B, and a whole lot of other diseases which can cause initially what is called as alcoholic hepatitis or steatohepatitis, which is basically inflammation of the liver. That's an early reversible stage, and at that stage we we do the right thing, it will get reversed. But if we don't recognize the condition, or if it is left uncared for, that will lead on to what is called as a fibrosis, which is basically a scarring of the liver. And eventually that will lead to a final stage of the liver disease, which is called as a cirrhosis. And that's when patients will start developing some symptoms like jaundice, accumulation of fluid in their tummy, legs, and then they'll develop some muscle weakness, tiredness, they'll have blood vomiting, or sometimes they may pass blood in the stools. In extreme conditions, they may even go in for what is called as a hepatic coma and complete liver failure. And in advanced stages, they may even develop liver cancers. So cirrhosis is basically an end stage liver disease, and which cannot be reversed by medicines anymore. And we can only manage them medically until we find them a definitive solution, which is liver transplantation, which is a life-saving and only definitive procedure for patients with end-stage liver disease or cirrhosis with decompensation. And of course, there is another set of patients who come in with acute liver failure, where they will not have any underlying liver disease to start with, but then all of a sudden they develop the failure of the liver due to a lot of reasons. One of them mentioned by Dr. Velmurugan is the rat hole poisoning, where people tend to consume the rat killer poison as with an intention, with a suicidal intention, or accidentally kids ingest them, and they end up with a complete liver failure, which happens over a period of 24 to 48 hours. They come in a very critical situation, and at that situation, the only scope for survival would be a liver transplantation. We do an emergency liver transplantation to save those patients. What are the reasons for cirrhosis? As previously mentioned, it is alcohol is a predominant cause. Alcohol, fatty liver, and hepatitis C and B account for almost 80% of the liver cirrhosis or liver failure in India or in most of the countries. And the remaining is contributed by other causes like autoimmune diseases and other tumors, metabolic and genetic disorders. But the predominant chunk is by alcoholic liver disease, which is still the #1 cause in India. And the #2 is fatty liver disease because of the change in the diet, westernization of our diet, high cholesterol intake, leading to fatty liver, and eventually moving on, leading to cirrhosis. So how do we decide if the patient needs a transplantation? Obviously, not all the patients with liver problem is going to need a liver transplant. The patients with cirrhosis, we calculate a score. That score tells us whether the patient is sick enough to undergo a transplant, or is the patient going to be benefited by a transplant. So that is called as a model for end-stage liver disease. That score tells us how sick the patient is, and is he going to survive? What is his survival for the next 90 days? Or what is his risk of dying in the next 90 days without a liver transplantation? So we calculate that score. Higher the score means higher the risk that the patient will die in the next 90 days. So we need to quickly consider a liver transplant. We explain to the patient, look, your score is high. You need to really consider liver transplantation at this stage. Medical management, there is only medicines will not help you at this stage. So that's when we start talking about liver transplantation. We have a cutoff score of 15 and above, beyond which the risk of not doing, without transplant, the patients will have a high risk of or high risk to life within the next 90 days. So what are the options available for these patients? There are two options. One is called as a cadaver liver transplant or deceased donor liver transplant, where the patient get waitlisted on a government waiting list, and then they wait for a brain dead donor, and the government allocates a liver to that particular patient. So that is called as a cadaver liver transplant, where the liver comes from a cadaver donor or a brain dead donor. And a living donor liver transplant is when a liver is taken from one of their family members. A part of their liver is taken from a family member and donated to them. These are the two options. I'll talk about it a little bit detail. So in a cadaver transplant, the patient will be evaluated by us. We make sure that the patient is suitable for transplant, and then we put them on the waiting list. The waiting list is managed by Tamil Nadu government, called as the Transplantation Authority of Tamil Nadu, which governs all the activities of organ donation, be that a liver or a kidney or a heart or a lung. They all get listed on the waiting list. And when a brain dead donor is identified in the state, it will get allocated to the patients based on their blood group and their seniority and priority. This is a very transparent system. Tamil Nadu government is doing an excellent job in this. In fact, we are the pioneers in organ donation in the country. In fact, other states have learned from Tamil Nadu. Somewhere about 200 to 250 organ donations happen a year. But still, that's a minuscule number which cannot cater the entire group of patients waiting for a liver transplant. That's why we have the other option called as, this is a cadaver transplant, where what you see on this side is a cirrhotic liver. This is a normal liver. This is how it should look, a smooth liver, which is a newly implanted liver, where this is a cirrhotic liver which is taken out of a patient who underwent a transplant, and this is a new liver which is taken out of a cadaver and which is ready to be implanted. It's sitting in a bath of ice. This is a cadaver transplant where the whole or a part of the liver is transplanted. And in a living donor, what we do is we take a portion of the liver. We cut a portion of the liver. Liver has this tendency to grow again. And we take that advantage. As Dr. Velmurugan said, it has got multiple segments. We can take almost 65 to 70% of the liver safely from a normal individual. Like as you can see, I'm holding like a 400, 500 grams of liver in my hand. That's taken out from a donor, and it grows in 6 weeks time. The liver grows almost to its full capacity within 6 to 8 weeks time. And when we put that in the patient, where this is where the whole liver was there, the cirrhotic liver that was taken out, and this half of the liver was implanted there. And this liver also will grow inside the recipient's body or the patient's body. So the liver can grow both in the donor body, the remnant liver, the leftover liver, and the part of the liver that I take out from the donor and put it in the patient will also grow in 2 to 3 months time. So we utilize that ability of the liver and do what is called as a living donor liver transplantation. And that we learned it from the liver tumor resections, because we cut the tumor out, we see that the liver regrows, and that's where we learned that the liver can be taken partly safely and given to another person. And living donor liver transplant is done. That's how we take out either the right half or the left half of the liver, or even like a small portion of the liver for the babies. And we do a living donor liver transplant. And pediatric living donor, it's we take even smaller portions, tiny portions of liver, like maybe 100 grams of liver and give it. This is one of our very young baby recently had a transplant. We do for a few months old babies to 70, 75-year-old people. Age itself is not a bar for us. As long as they are suitable for a liver transplant, we do a liver transplant. You can see that's a liver taken out, and that's a portion of the liver that was given inside the baby. Success rate, there seems to be some misconception about liver transplant among public, that liver transplant is a scary procedure. It's a major one, may not have a very good success rate. But to put it in simple terms, the success rate of liver transplant in India, I'm not even talking about the Western world, in India itself is over 95%, both for adults and children. And what I mean is, when I transplant 100 patients, 95% of them will go home without any problems, a very smooth standard like any other simple operation. Of course, 3 to 5% of them will have some issues, mainly because they reach us at a very late stage. And when we plan for a transplant, they're already very sick, and some of them may have a stormy recovery, but still 95% and over of them will go home with a very smooth recovery. Both living donor and cadaver has an equal success rate. In fact, the outcome of transplantation in India is slightly superior than the Western world, mainly because we have a quick access to living donor liver transplantation. What are the other areas apart from the routine indication, which is the alcoholic liver disease, fatty liver, and hepatitis? The other common indications nowadays, it's coming up. Almost 15-20% of our transplants are done for liver cancers. As Dr. Velmurugan sir mentioned, hepatocellular cancer, which is a primary cancer of the liver, cholangiocarcinoma, which is a cancer of the bile ducts, and neuroendocrine tumor, which is a special form of tumor which can spread to the liver. All these things can be now cured with liver transplantation. Unlike before, when these cancers come in a big stage, we really don't do much other than, if we can't, particularly in a cirrhotic settings, where when there is a cirrhosis and when there is a cancer, we can't cut out a part of the liver because the whole liver is not working well. If you take half the liver, the rest of the liver will fail. So we need to so for these kind of patients, we take out the entire liver with the tumor and then give them a new liver. So we essentially cure those patients with these cancers, and particularly when they arise in the background of a cirrhosis or a fibrosis. And now a lot of liver transplants are done for liver cancers, cholangiocarcinomas, and neuroendocrine tumors. And we also do, normally, I'll come back to this slide after this slide. So normally what we do is, what we all know is, we need to do some matching, obviously, between the donor and the recipient. We all know that blood group is a crucial one. When we do a blood transfusion, we give a A group blood to an A group. Similarly, we used to do liver transplants and kidney transplants with blood group matching. Basically, a A group liver is given to an A group patient. But now, in the last 10 to 15 years, what we have done is called as ABO incompatible or mismatched transplants, which is another important thing the patient has to know. You don't need to really look for a donor with the same blood group, because now we can give donors, even if the donors have a different blood group, we can give that. For example, if the patient is a B patient and if they have a donor who's A, the B patient will have in their blood a chemical which can act against an antibody which can act against the A liver. So what we do is we basically take out their blood, filter it, and remove all those antibodies prior to putting in the A liver. So the B patient can accept the A liver after filtering the blood, just like a dialysis. We do 2 or 3 sessions of dialysis, and then their body can accept an A liver. And the ABO mismatched transplants have an outcome as good as the ABO matched transplants. So nowadays, I don't really tell my patients, look, you need to bring you're an A group, you need an A group donor. I tell them, as long as you have a donor in your family, you just bring them, we'll see the medical suitability. And even if they are of different blood group, we can still use the liver by doing this additional treatment where we filter his blood, take out the particular antibodies, and then put in the new liver. This is one option of increasing the donor pool. Basically, we are increasing their option of getting transplanted. The other option is a swap transplant. Sometimes They may have a patient, maybe B group. He may have a donor who's A. I may have another patient with the A group, and he may have a donor B. So what we do is we exchange the donors between the two patients, and that is called as a swap transplant. We've done that as well. That also increases the chances of getting a liver transplant. Otherwise, they'll have to go either for a AB compatible transplant, or they may have to wait for a cadaver transplant, or someone they have to look for a different donor. Living donors. So as I mentioned, the living donor who can donate, anyone in the family. It has to be a family member. It can't be an unrelated person. It's not legally allowed in India to do unrelated organ donations. So a living donor has to be a related donor. Anyone in the family, male or a female, 18 years to 55 years. 18 is a legal age limit, and 55, because above the age of 55, the growing capacity of the liver is a bit lower as we age. So we tend to use only 18 to 55-year-old donors, male or female, anyone from the family can donate. What we do is we do a small surgery for them, and take out a portion of the liver. As I mentioned before, the portion of the liver that we take out depends on the weight of the patient who's receiving. For example, a 70-kilo man will require somewhere about 560 grams of liver. So we calculate the volume of the liver the patient is going to donate. On an average, a 70 kg human will have somewhere about 1.2 kg to 1.4 kg of liver. So someone can donate almost 65% of their liver safely without any issues at all, which means that I can take out somewhere about 800 grams of liver. So normally a 60 kg man will only require about, I would say about 480, 500 grams of liver. So we take out only 500 grams of the right portion of the liver or the left portion of the liver by surgery. And that, as I mentioned before, the liver grows within 4 to 6 weeks to almost its 90% capacity, and it continues to grow over the next few months and achieves its full potential by 2 months' time. And the donor procedure is absolutely safe. We do a thorough evaluation to ensure that the donors are safe both in short term and in long term. If the donor had to live a normal life of 80, 85 years with or without donation, they will still, even after donation, they'll still continue to live 80, 85 years. It doesn't matter. In respect, the donation will not have any impact on their life expectancy at all. Because the liver regrows and they will lead an absolutely normal life. There are young girls, young boys who give donated liver to their parents. They got married, they had kids, and they're leading an absolutely normal life. In fact, there are athletes who donated livers and went back to athletics and sports. There are transplant patients who had living donor transplants, went back to playing sports, including participating in national level athletics. So that is how common now liver transplant is and liver organ donation is. Previously we used to do this donor operation with open operation, but now with the advances in the surgical technique, laparoscopic technique, and robotic procedures, we are now doing the laparoscopic, the donor operation with laparoscopic and robotic technique, which is basically a keyless keyhole operation, where we don't make a big scar, we make a few holes, put the camera inside, cut a portion of the liver, and we just take out the liver. We just make a small cut only to take out that portion of the liver that we need to take out. By doing that, pain is much less. They have a much quicker recovery. They go home on third day after a surgery, and they return to work in 8 to 10 days time, which is a phenomenal recovery for a donor point of view. And unless they go out and say that I've donated a portion of the liver, no one would even assume that they are a liver donor. That's how healthy they will look after a donor. Not only donor, even a transplant patient, unless they go out and say I had a liver transplant, people not even assume that these patients had a liver transplant. That's how normal they would be. They'll be like you and me, like a normal life. So that's the difference in the scar. You can see this is how we used to make a cut for open donor operation. And nowadays, this is how the couple of small spots here and there, 4 spots here, and the liver will come out through this little scar in the bottom of the belly. So someone wears a pant or some sari or something, they won't even see the rest of the scar in the belly. And this, in fact, is a young girl, 19-year-old girl who donated a portion of a liver for her father, did a robotic donor hepatectomy for this girl. And she went home on 4th day and appeared for her engineering exams within 7 days. That's how quick her recovery was after a liver donation. So to put it in a nutshell, liver transplant is liver transplant is a very common procedure nowadays. Somewhere about 3,000 to 4,000, 3,000 plus liver transplants happen around the country in India, which is a very high volume compared to the rest of the world. And living donor liver transplant has been pioneered in India, particularly the area of living donor surgery, robotic living donor surgery, laparoscopic living donor surgery has been pioneered in India. Outcome has been over 95% both for adults and children. Donor surgery is absolutely safe, and we ensure that donor safety is our priority. We make sure that the donor thoroughly evaluated prior to donating liver, and donating liver will not have any impact on their long-term life expectancy. Thank you. I'm happy to take any questions.
Thank you so much. I have a few questions of my own, but before that, just a reminder to all our audience, please feel free to share your questions in the Q&A box. We have about 15 minutes left of our conversation this morning, and we would love to address any questions that you might have for the doctors about any concerns, clarifications, doubts regarding liver health in general. But I will start with Dr. Velmurugan, perhaps for the first question. You spoke briefly in your presentation, but I think it would be good if you could talk to us in a little more detail about when doctors suggest removing part of the liver, and when you go into the transplant phase.
Right. As I told earlier on, if the liver, we can remove up to 2/3 of the liver if it is a healthy liver. So we look at the liver function test, and also we look at the imaging and look for any evidence of cirrhosis. If there is no cirrhosis and if the liver is healthy, if the tumor is involving 3 or 4 segments, we can go and remove up to 6 segments. We can do an extended liver resection. The remaining 2 or 3 segments will be enough to regrow. But you cannot do the same thing if the patient has got cirrhosis of the liver and if it is a damaged liver due to fibrosis. If you remove even 40% of the liver or 30% of the liver, the remaining liver may not be enough. So what we do is we have, if it is a diseased liver, there is a scoring system called Child's scoring system. Child's A means mildly diseased liver, where you can remove 30 to 40% of the liver without major issues. Even then, we can't go up to 60-70%, even in a child's A cirrhosis. But if it is a child's B or C cirrhosis, basically this calculation is done based on the liver function blood test and the clotting factors. If it is a moderately or severely damaged liver, which is the child's B and child C cirrhosis, then you cannot do removal of the part of the liver because the remaining liver will not be enough. Then they need a transplant. Any liver tumors, the primary modality is removal, but if you can remove the liver with enough residual functional liver volume which will keep the patient alive, then resection or removal is the primary treatment. I'm sure Dr. Swaminathan will agree as well. Suppose if the remaining liver will not be enough from the assessment, then we cannot remove part of the liver, then the only option will be a liver transplant. But even for a liver transplant, there are certain criteria. We go through the criteria, and if we satisfy the criteria, then we will do a liver transplant. And if we do a liver transplant, these people, as Dr. Swaminathan said, we can achieve a cure in HCECs and neuroendocrine tumors and cholangiomas, islet cholangiomas. So The primary modality of treatment for liver tumors which needs to be removed is removal only, as long as you will have enough remaining functioning normal tissue to carry on with the life of the patient. If it is not possible, then transplant is the option. If that is not possible, if it's not fitting into the criteria, then we move on to other modalities like local treatments, just killing the liver, the damage, the tumor alone, or we go for chemotherapy and radiotherapy, which is given through the catheter into the artery, liver artery, the blood supplying artery. So these are the treatment modalities.
Sure. Thank you so much. I will follow that up with a couple of questions from the audience on the causes of fatty liver. If you can talk to us a little bit about what causes fatty liver.
Right. The fatty liver is basically it's a metabolic problem. So the liver metabolizes majority of basically it's a metabolic organ. Liver is a metabolic organ. People all think that if I eat too much fat, I will get fatty liver. No, the answer is wrong. There is clear evidence now. It's the carbohydrate which causes the fatty liver. The fat what we eat, for example, if you have a little bit of ghee or whatever it is, then it doesn't cause fatty liver because it gets metabolized. The fat gets metabolized. The fat will not deposit as a fat in the liver. Only the carbohydrate. If you eat too much carbohydrate than what is needed, then that will get converted into fat by the liver and gets deposited in the liver. So its answer is too much carbs, soru, and all this fast food. Yeah, I get patients saying that I don't eat too much soru. I have only a little bit of soru. Then what do you eat in the breakfast? They said, I have idlis and dosas. Is it made of iron or rock? It is made of soru. It's the same rice in a different form. And I eat appam. Again, it's carbohydrate. It's the same soru. I eat upma. Again, it's carbohydrate. I eat pongal. Again, it's carbohydrate. We eat carbohydrate in different forms. We eat carbohydrate only. Do you take a lot of vegetables? No. If I say vegetables, I eat potatoes, chips, then bananas and all those things. So they are not rich in fibers, and they are carbohydrates actually. You need to have vegetables which have high fiber content, like cabbage and all the greeny vegetables, and so all those things. So its main answer is carbohydrates. Cut down the carbs. Have more millets and fruits and veggies. That's the basic thing. And cut down all the fast food like pizzas and burgers. I mean, you can have it once in a while, maybe once in 4 months or 6 months. You can't be, like a Muniva, not eating anything. You have to have once in a while, you have to have it, but don't have it very frequently. Don't spoil your children. We see fatty livers even in children now. I'm sure that Swaminathan will agree. It's very sad. We are seeing so much obesity and fatty liver in younger people. Yeah. Thank you.
One last question on this line of questioning before we move to a question for Dr. Swaminathan. You spoke about once in a while and lifestyle habits and food. We have a question about, since the liver regenerates itself, is occasional drinking okay?
Right. This is a very difficult question to answer. How much you drink matters, and what you drink matters. I mean, once a month, if we have it depends upon how much units you consume. For example, if you have a beer, full beer, it's about 2 units. If you have a glass of wine, it will come to probably one unit or so. Or if you have a small whiskey or something, it will be 2 units. As long as you are taking just 2 units a month, it'll be okay. But the once a month is okay as long as you take it in very minimal amount. But if you're taking once in a month, people binge. They go for a party, they binge, they drink, they finish half bottle of whiskey, or they drink 4 or 5 beers. Then it becomes too much for the liver to handle. So it's not only the alcohol, the side dish causes more problems than the alcohol. They eat too much during the time, and all of them will be carb-based and oil-based, spicy things, and which will harm the liver as well. So occasional limited alcohol is okay, but it's important here to maintain that the limited alcohol. I have to underline that limited alcohol. That's very, very important.
Thank you, doctor. I think indulgence and moderation for
Yes.
food and drink is basically the answer. But moving on to a question for Dr. Swaminathan, your profile that I was reading before we started speaking also spoke about how you performed the second youngest pediatric live donor liver transplant in Tamil Nadu on a 6-month-old. Can you speak to us a little bit in detail about transplantations in children? Are there any longer term side effects or deficiencies that we need to keep in mind, and what is that like?
Thanks for bringing up. Actually, pediatric transplants are now routinely performed, and in fact, our team has done a reasonable volume of pediatric transplants, starting from a few month-old babies to teenagers. They do exceptionally well compared to adults. The kids bounce back very quickly. You wouldn't be like, you'll be surprised to see them after a few months. They'll be jumping up and down and playing like any kid, without even knowing or without even realizing that they have a liver transplant with them. And they actually teach us a lot. They actually tell us that liver transplant can be done successfully. And in fact, they are the living examples of how a good functioning liver will bring you back to a normal life. Yes, the question about the younger they get the liver transplant, unfortunately, some of the kids, most of these transplants are done for some sort of a disorder in the bile duct, or some sort of a genetic disorder that affects the liver, like what we call as a biliary atresia, where they're born with the bile ducts being improperly formed. They develop some genetic disorders where there are some metabolic disorders which can affect the liver. And so most of these pediatric transplants are done for something which they are born with, or something they acquired very early in their life. These patients will be put on rejection medicines to keep the liver going. When they get a transplant, they get a rejection medicine going. And that rejection medicine is something that they need to take lifelong, as long as the liver is in them. They just need to be a little bit more careful. And as they grow and they become a teenager, the transition period is a crucial time when they kind of get a little out of control from the parents. As long as they're kids, the parents give them the medicine, they take care of them well. And then the teenage is a time when they kind of go out of control. They start picking up some habits, and we just need to be carefully monitoring the transition period. But apart from that, I've seen kids who got transplanted in 80s. I'm talking about now almost 40 years with a functioning liver, although I haven't done them. But I've seen the patients who got transplanted way back in the 80s and 90s, where the mother donated a portion of the liver, and they still, I've even have a few patients who are doctors themselves who had a liver transplant back in 90s and gone to become a doctor. And in fact, there was one who's gone to become a hepatologist, who's a liver specialist in US, who himself is a pediatric liver transplant recipient back in the 80s. So that's a standing example to tell that this liver is a resilient organ. Once it's put in and it starts working, the first 3 months you cross that and your life is like any other normal person.
Perfect. And last question, perhaps, I know we're almost at time, but are there any specific conditions that impact the ability to be a living donor? Any pre-existing health conditions, for example, that might affect the ability to donate?
Yeah. One of the important things we look into the liver is the quality of the liver, a fatty liver, or someone who's been regularly using alcohol, patients who have uncontrolled diabetes, high blood pressure, heart problems. We make sure that the person who's going to donate should be absolutely normal. They don't have to be, there are patients who are well-controlled diabetic who has donated livers, well-controlled hypertension, high blood pressure can donate livers. But then we check them thoroughly. We make sure that their health condition does not have an impact on the liver as well as on them on long term by donating half of the liver. So we check the quality of the liver by doing some blood tests. We do some scans. We look at the quality of the liver, and also we look at the general health, whether they are suitable to go through a surgery to donate a liver. We look at their heart, we look at their lungs, quality of the liver. By taking out the half of the liver, am I going to put the donor at risk in long term? All those things will be thoroughly evaluated, and only then we take it. But then we look at each individual separately. There are incidences where patient had a fatty liver, they are motivated, they went on to do 6 weeks to 8 weeks of training program like diet and exercise. They lost their weight 10-15 kilos, the fat got melted from the liver, and they went on to donate for their husbands. So it's like it's a reversible condition. A fatty liver is a reversible condition, and we do do a careful evaluation before considering those type of livers.
Thank you so much. I think if we've all take away a few things from today, it will be that liver disease is extremely manageable, and we do have the systems and the expertise at hand to manage any condition that might come up. And perhaps as far as prevention goes, indulgence and moderation, like Dr. Velmurugan was saying, is the best way to go. But on the eve of World Liver Day, it seems like a good note to end this on the resilience of the organ and the skill sets that we have available to any of us who might need help. Thank you so much, Dr. Velmurugan and Dr. Swaminathan, for joining us today on behalf of Kauvery Hospital and the Hindu. Thank you to our audience for spending an hour of your morning with us. It was a pleasure hosting you all.
Thank you. Good day.
Good day.